The patient is in the driver's seat if they need to take a break, if they want to travel. We're not bound by the every 3 weeks cycle.
Let me ask you, as we think about individualizing therapy, when you use the DB09 regimen, are you treating to progression, or are there other strategies that you're deploying for the use of T-DXd and pertuzumab in the first line?
So I follow the clinical trial protocol. So disease progression, unacceptable toxicity, or if a patient opts out. And we're flexible. The patient is in the driver's seat if they need to take a break, if they want to travel. We're not bound by the every 3 weeks cycle. We can extend this and be flexible in adjusting this. And oftentimes these deep responses, in my experience, last very long. So I'm going to have patients that, for whatever reason, interrupt for 6 to 8 weeks. They see no change. Look, a lot of ctDNA in my practice. So I think this is something that we handle as part of the practice of medicine very flexibly. There are strategies that are looking at de-escalation strategies. I think they're very early. I think they're not ready for practice or prime time. So I try to discourage something that I would like to do, which is to de-escalate from actually implementing it when I don't have any good data set to support it.
Yeah, I think that's very fair. And as we start to see more maintenance strategies coming out that are typically using the THP induction regimen, I think we are starting to think about what is the most successful induction strategy, and certainly the response rates for T-DXd are quite compelling, but stick to the trial and stick to the data. A common theme that I often hear is, what do we do after T-DXd? And I think, in my mind, I frame it such that we're really optimizing the disease state, going back to our conversation of using our best therapies up front. If we can hit the disease with a bang and induce the best response possible, I see that as really optimizing the disease state for subsequent lines of therapies when progression does happen. What would your counsel be to a colleague who is concerned about subsequent lines of therapy?
I think that's a legitimate question. We're changing the entire disease space by moving questions around. For me, I'm more pragmatic when it comes to decision making. I have to make a decision about the best therapy at any given time. So when I'm at the point of decision making before first line therapy, clearly T-DXd is the most efficacious regimen. When it comes to progression, I do have to extrapolate. I know that there are many drugs available, none of which have been validated post T-DXd. So it becomes a little bit more challenging, and I would individualize it. And this would also be a great opportunity for a clinical trial. I think if it's brain metastatic patients, I think a tucatinib-based regimen would be of great interest. But I think any other therapy afterwards hasn't been really validated. Obviously, T-DXd is going to push that question far into the future, and maybe we'll have more insights by the time that this progression happens. So obviously, also molecular sorting might help us select the most optimal therapy.